Thank you. So today we're going to be talking about my project, which was the surgical anatomy of the Pterion and its relationship to the middle meningeal artery in optimizing pterional craniotomies, and it's a cadaveric perspective. So most of us here know what the Pterion is, but just a brief overview, the Pterion is an anatomical landmark on the lateral aspect of the cranium formed via the junction of the frontal bone, seen there, the parietal bone, the squamous portion of the temporal bone, and the greater wing of the sphenoid bone. Morphometrically, the Pterion is classically described as an H-shaped landmark situated approximately 4 centimeters superior to the midpoint of the zygomatic arch, which is right here, and 3.5 centimeters posterior to the frontozygomatic suture, which is over here. As it turns out, the H-shaped Pterion that we're taught about in anatomy is one of 4 classifications. Morphological variation of the Pterion was first established and classified by Broca in 1875 and further expanded on into an actual classification system by Murphy in 1956. Each of these 4 classifications differs based off of which of the bones are in direct contact with each other and forms the majority of the suture. So type 1 Pterions are also known as phenoparietal Pterions, which is going to form the classic H shape that students are expecting to see when they look for the Pterion. This articulation is going to occur between the parietal bone up here and the greater wing of the sphenoid bone. Type 2 Pterions are also known as frontotemporal, which are going to form more of a K shape. Sometimes they look like a K, sometimes they don't really. But the big thing is that the direct contact is going to be between the temporal bone and the frontal bone. Type 3 Pterions are also known as stellae, which form an X shape or a star shape on the lateral aspect of the skull. And in this type, you have all 4 bones that are in direct contact with each other. And then the 4th type is the epipteric Pterion. And these are going to exist when there's an extra bone or an epipteric bone within the suture line of the Pterion. So on the right here, you can see an example circled in the middle. This is an extra bone within those suture lines, making it a type 4 Pterion. This type in particular poses additional risk as that additional bone can impact accurate visualization because on many scans, it looks like a fracture. So if you're not aware of this type, then you might think that someone fractured their skull. As a remnant of the anterolateral fontanelle of the neonatal skull, the Pterion is notably the weakest part of the cranium, and it coincidentally overlies the anterior branch of the middle meningeal artery in many cases. Due to the location and structural characteristics of the Pterion, it's a commonly utilized entrance point during neurosurgical procedures, specifically during Pterion approach craniotomies. During a Pterion approach craniotomy, an incision is made behind the hairline on the anterolateral aspect of the cranium. The skin, temporoparietal fascia, and temporalis muscles are carefully dissected and reflected inferiorly to allow visualization on the cranium, as well as the zygomatic arch and frontozygomatic sutures. Following reflection of the soft tissue, the first burr hole is drilled superior to that frontozygomatic suture, with additional burr holes being placed at the discretion of the surgeon. Some surgeons want burr holes placed in a circular pattern, as you can see in this figure here. Other surgeons just want the one, and they haven't experienced that they make it all the way around where it needs to be. But the ostomy is going to then be continued from the initial burr hole along the superior temporal line before curving inferiorly to include the Pterion and then anteriorly to connect back to that initial burr hole, making the bone flap. Once the flap is cut, blunt dissection is then used to carefully detach dura and associated branches of the middle meningeal artery from the internal aspect of the bone, allowing for complete retraction of the bone flap, hopefully without damaging any of the vasculature. The Pterion approach craniotomy is a favored approach for many neurosurgeons due to the many benefits associated with the procedure. Entrance through the Pterion provides optimal access to the anterior circulation of the brain. as well as various intra and extraaxial structures of the anterior and middle skull base. Since the pterion overlies the lateral fissure of the brain, there's a decreased risk of damage to the brain as less tissue retraction is necessary to get to the deeper structures. Finally, due to the placement of the initial incision posterior to the hairline, there are cosmetic advantages to this procedure, as well as a lower risk of postoperative temporalis muscle atrophy compared to standard craniotomy. As with any procedure, there are risks associated with this approach, largely iatrogenic epidural hematoma formation due to injury to the middle meningeal artery. There's also a risk of palsy of the frontal branch of the facial nerve due to damage during soft tissue retraction at the beginning. Due to the seemingly vast amount of variation in pterion morphology and the importance of locating and utilizing the structure during numerous neurosurgical procedures, this project aimed to identify the prevalence of each pterion classification, while determining an approximate location of each in comparison to commonly utilized anatomic landmarks. Secondarily, this project aimed to uncover the relationship between each classification and the middle meningeal artery. When it came to specimens, we were able to use 49 formalin embalmed cadavers on both the Joplin and Kansas City campuses, consisting of 42 bilateral dissections and 7 unilateral dissections for a total of 91 pterions analyzed, with 47 on the right and 44 on the left. Ultimately, we were able to study 25 females and 24 males with an average age of about 70 years. When it came to a dissection, a lot of the superficial soft tissue was removed from the skulls during the first-year medical student dissections in lab, and transverse cuts were made in the cranium, in most cases superior to where we estimated the location of the pterion to actually be located. The temporalis muscle was removed from the temporal fossa bilaterally, and suture lines were scraped clean to expose ultimately up to the bregma and the inion. Following removal of the brains for the first-year dissections, data was reflected from the internal surface, allowing visualization of the pterion on that internal surface and the group for the middle meningeal artery. To obtain measurements with some kind of standardization here, the pterion center had to be established and marked for each type. Based off of different articles and different studies that have been conducted, there was numerous ways to do this, but ultimately we settled on, in types 1 and 2, the center was designated to be the midpoint between the two bones that were in direct contact. In type 3, the center was the point at which all 4 bones came into direct contact with each other. And then in type 4, the center was noted to be at the center of the epiteric bone itself. When it came to the actual measurements for the study, we collected distances in centimeters from the center of each pterion to the frontozygomatic suture, the midpoint of the zygomatic arch. So those are the two that have the main characterizations and distances that a lot of surgeons use. But we also added the distal most aspect, or the tip of the mastoid process, the anterior border of the external acoustic meatus, the bregma, and the inion. Additionally, we measured the distance from the pterion center on the internal surface of the cranium to the groove for the middle meningeal artery, making sure to also check for the presence of bony bridges, which is something we'll talk about in a few slides. Finally, the last measurement we collected was the thickness of the skull at the pterion center when we were able to get the calipers in the right spot. When it came to statistics, the numerical data was run with descriptive studies to determine mean, standard deviations, and ranges for everything. When it came to categorical data, we used an independent t-test to demonstrate differences between pterion type and laterality, as well as between type and gender. We used a chi-squared test to analyze the difference between type of pterion and having bilaterally identical pterions. And then ANOVAs were run to look for differences between pterion type and distances to the 7 anatomic landmarks. And then we used a significance level of 0.05 for all of the results. All right, so for results, the first piece of data that we looked at was the overall prevalence of each pterion classification in our sample of cadavers. So holding consistent with previous studies, type 1 pterion morphology was the most common type, seen in about 67% of our sample. Type 3 was the second most common, seen in about 16%, followed by type 2, which was seen in 11%. The least common variation noted was type 4, which was demonstrated by only about 5% of our cadavers. While type 1 was the most common, and that was consistent with other studies, these other three types varied from previous studies. Every study that I looked at had very different numbers in prevalence, but there's a lot of factors that can affect that as well. But upon further evaluation of the data, there was no significance between type of pterion and laterality, nor between type and gender. However, one of the most interesting pieces of information, in my opinion, that we uncovered was that out of the 42 cadavers we were able to get bilateral information on, only 22 of them had the same type of pterion bilaterally, meaning that about 48% of these cadavers had differing pterion types on the right and the left. Further analysis of that information showed statistical significance between type of pterion and the prevalence of being bilaterally identical, with type 1 being demonstrated in 87% of these crania. While bilateral presence of identical pterions proves statistical significance, the distance between pterional center and the 7 anatomic landmarks did not have any significance when it came to laterality. However, statistical significance was found for 3 out of the 8 measurements obtained between the 4 pterion classifications, which included the distances from the pterion to the frontozygomatic suture, the distance from the pterion to the middle meningeal artery, and then the skull thickness at the pterion. With the frontozygomatic suture, type 2 pterions were located the furthest distance from that suture, on average about 7 centimeters, while type 3 pterions were located the shortest distance, about 4 centimeters. On the internal surface of the cranium, the center of type 3 pterions was situated closest to the groove for the middle meningeal artery, on average about 0.16 centimeter, with type 1 pterions being the furthest from the groove at about 0.35 centimeters. Additionally, skull thickness at the center of type 3 pterions was the thinnest, on average about 0.23 centimeters thick, in comparison to type 4, which demonstrated the thickest skull at 0.49 centimeters. These findings of skull thickness at pterional center are of particular significance due to their correlation with strength and integrity of the sutural junction, demonstrating the thinnest skull at the pterion center and the closest relation to the groove for the middle meningeal artery. Type 3 pterions pose the greatest risk for epidural hematoma formation due to arterial rupture via iatrogenic or traumatic injury. Another factor that was noted to impact the location of the pterion is gender. When analyzing the impact of gender, statistical significance was found for 5 out of the 8 measurements, including the distances from the pterion to the bregmon, the inion, frontozygomatic suture, tip of the massoid process, and the external acoustic meatus. This finding emphasizes the importance of careful pterion localization, as all of the distances were shorter in the female donors as compared to the male donors, which is a finding that's not unexpected, as sexual dimorphism is a well-documented phenomenon in human skulls. The differences in male and female skulls are further confirmed by the statistically significant differences between pterion location in relation to the anatomic landmarks found. This finding is of particular significance due to the previously established and widely utilized parameter for pterion localization of being 3.5 centimeters posterior to the frontozygomatic suture. In comparison, this study's evaluation of the 91 pterions redefines the parameter to 4.85 centimeters posterior in males and 4.26 centimeters posterior in females, which is quite a range there. So part of why this is so important is the anterior branch of the middle meningeal artery courses within a groove in the middle cranial fossa, where it then curves along the greater wing of the sphenoid bone and deep to the pterion, as you can see here. As the middle meningeal artery courses within the groove, it becomes incorporated into the layer of periosteum adjacent to the dura, where it adheres to the cranial bones. In some individuals, a bony bridge forms within the groove of the middle meningeal artery, as you can see here. This aberrant piece of bone converts the open groove into a tunnel, which results in the inability to separate the artery from the periosteum, thus resulting in the inability to reflect the bone flap and expose the underlying dura and brain without damaging the artery. Bony bridges were seen in approximately 65% of middle meningeal grooves that we were able to look at in the lab, with the largest prevalence in those of type 1 Pterions, so about 67% of those. Types 2, 3, and 4 each demonstrated bony bridges in approximately 60% of the skulls. So why does any of this really even matter? This study demonstrated the importance of preoperative visualization of the Pterion. While there are reference points and distances utilized by many surgeons to provide a generalized location, we've shown that there are numerous factors that can alter that location, thus resulting in complications such as orbital roof fractures and/or vascular compromise. Characterization of the Pterion prior to surgical intervention, if it does occur, it often is done through 3D reconstructed images of CT scans, which is demonstrated on the left here. This can aid in reducing complications caused by poor localization of the true pterional center, especially when it comes to type 4 pterions, since the front of the epiteric bone can be mistaken as the center, which could then lead to you penetrating the orbit if you decide to go and enter the skull there. Recent studies have also proposed the use of cone beam CAT scans to visualize the pterion, which is demonstrated on the right over here. You can see the pterion in here. And it's an imaging technique that could potentially be combined with angiography to potentially characterize the relationship with the middle meningeal artery. However, that is all still being done on a case-by-case basis, so it's not standard at all. One of the largest limitations of the present study was that all of the cadavers we had the ability to work with were Caucasian. Previous studies have suggested that race and ethnicity may impact the prevalence rates of the different Pterion types, as well as the overall location of the Pterion. So having the ability to measure these distances in individuals of different ethnicities and rates can help to see if what we found is a common thing or if what we found is consistent for Caucasians, but not other ethnicities. In the future, we could potentially look into trying to obtain medical records of those who present with epidural hematoma formation due to Pterion fracture and see if we can figure out through imaging what type of Pterion they had, which would ultimately help to see if the data correlates with what they're seeing practically in the emergency room, to see if what we found with type 3 Pterions being the thinnest and the shortest distance from the middle meningeal artery actually has an impact on people. And then trying to find out more about bony bridge formation, seeing if there are other factors that impact the formation of these variations, such as hypertension or stuff like that. In conclusion, the study showed the importance of surgeons being aware of the 4 Pterion morphologies and how their locations vary within the skull. It also demonstrated the prevalence of bony bridges in the group for the middle meningeal artery and the importance of acknowledging that anatomical variation prior to surgery and being prepared to deal with it if necessary. And then I just wanted to say thank you to all the fellows and faculty in the anatomy department, specifically Erica and Dr. Sloan for helping with this project, and then just a thank you to all the donors for allowing us to work on their bodies.